Diseases of thyroid hormone. Hyperthyroidism. Hyperthyroidism is related with the overactivity of thyroid. Hyperthyroidism can be due to the Graves' disease, and it can be because of thyroid adenoma, and it can be because of secondary access to secondary to the excess hypothalamus and pituitary hormone secretion. First of all, the Graves' disease. The Graves' disease is also known as toxic goiter or thyrotoxicosis. It's an autoimmune action against the thyroid gland. The body's immune system reacts against its own tissue, the thyroid gland. It's the most common form of hyperthyroidism, and it is an autoimmune disease in which the antibodies, which are known as thyroid stimulating immunoglobulins (TSIs), they are formed against the TSH receptors in the thyroid gland. These antibodies then bind with the same membrane receptors that bind TSH, and they induce the continual activation of cyclic AMP system of the cells. This results in the development of hyperthyroidism because the TSIs have prolonged stimulating effect on the thyroid gland, so lasting for as long as 12 hours in comparison with 1 hour for TSH. This high level of thyroid hormone secretion is caused by TSI, and it suppresses the anterior pituitary TSH formation. The thyroid hormone secretion increases 5 to 10 times normal. And because of the negative feedback effect on pituitary gland, the TSH levels are concentrations in the blood are less than normal. The antibodies that cause hyperthyroidism almost certainly occur as a result of autoimmunity that has developed against the thyroid tissue. The symptoms of hyperthyroidism are obvious from the preceding discussions of the physiology of thyroid hormones, and they include a high state of excitability, intolerance to heat, increased sweating, mild to extreme weight loss, varying degrees of diarrhea, muscle weakness, nervousness, extreme fatigue, inability to sleep, and tremors of the hand. Most of these effects are related with the increased metabolic rate, which is because of the increased thyroid levels. As we know that the thyroid hormones increase the basal metabolic rate of a person, so the BMR is greatly increased in hyperthyroid patients. If you revise the physiological functions of the thyroid hormone on different body functions, on different systems of the body, you can easily understand the effects of your symptoms of hyperthyroidism. Exophthalmos. Most people with hyperthyroidism show some degree of protrusion of the eyeballs. This condition is known as exophthalmos. It is characterized by swelling of the tissues in orbits, resulting in protrusion of the eyeballs. And sometimes this protrusion is so severe that the eyeball it stretches the optic nerve to damage the vision. The eyelids do not close completely when the person blinks or is asleep, and the epithelial surfaces of the eyes become dry and irritated and often infected. This results in ulceration of the cornea. The cause of this protrusion of the eyes is the edematous swelling of retroorbital tissues and degenerative changes in the extraocular muscles. In most of the patients, the immunoglobulins that react with the eye muscles can be found in the blood. Further, the concentration of these immunoglobulins is usually highest in patients who have high concentrations of TSIs. Therefore, like hypothyroidism, exophthalmos is likely an autoimmune response. This is usually greatly ameliorated with the treatment of hypothyroidism. These are the figures showing the symptoms of hypothyroidism. If you concentrate on this figure, you can see the swelling in front of the neck. This is the diffuse swelling that is caused by the Graves' disease. It's a diffuse swelling because the whole gland is greatly enlarged, and the eyes, as you can see, the eyes are protruded. They are known. This is known as exophthalmos, and it's a hallmark of hyperthyroidism. Thyroid adenoma. Hyperthyroidism occasionally results from a localized adenoma, and adenoma means a benign tumor of the pituitary gland. It's a benign tumor of thyroid gland. It develops in the thyroid tissue and secretes large quantities of thyroid hormone. But the presentation is different from the usual type of hyperthyroidism, that is Graves' disease, because in this type of hyperthyroidism there is no evidence of autoimmune disease. And as long as the adenoma continues to secrete thyroid hormones, the secretory functions in the remainder of the thyroid gland is almost totally inhibited, because thyroid hormone from the adenoma depresses the production of thyroid stimulating hormone by the pituitary gland. So, in thyroid adenoma, there are decreased levels of thyroid stimulating hormone, which results in the decreased production of thyroid hormones from the normal tissue of the thyroid gland. And there are increased production of thyroid hormones from the adenomatous or the tumorous cells of the thyroid gland. How can we diagnose hypothyroidism? After, along with the routine tests, the usual case of the hypothyroidism, for a usual case of hypothyroidism, the most accurate diagnostic test is direct measurement of concentration of in the blood, free thyroxine in the blood, and the basal metabolic rate is usually increased to plus 30 to plus 60. In severe hyperthyroidism, concentration of thyroid stimulating hormone in the plasma is measured by radioimmunoassay. The concentration of TSI can be measured, and it is measured by radioimmunoassay. This is usually high in thyrotoxicosis but low in thyroid adenoma. High concentrations. Now, the treatment of hyperplastic thyroid gland with radioactive iodine. 80 to 90% of an injected dose of iodine is absorbed by the hyperplastic toxic thyroid gland within 1 day after the injection. So, if the injection of iodine is radioactive, it can destroy most of the secretory cells of the thyroid gland. Usually, 5 millicuries of radioactive iodine is given to the patient, whose condition is reassessed several weeks later. If the patient is still hyperthyroid, additional doses are administered until normal thyroid status is reached. The most direct treatment for hyperthyroidism is surgical removal of most of the thyroid gland. The patient is first prepared for the surgical removal by administering propylthiouracil, the anti-thyroid drug, usually for several weeks, until the BMR of the patient has returned to normal. Then high concentration of iodides for 1 to 2 weeks immediately before operation causes the gland itself to recede in size and its blood supply to diminish. Because iodides in high concentration decrease all phases of thyroid activity, they usually decrease the size of thyroid gland and especially decrease its blood supply. In contrast to the opposite effects caused by most of the other antithyroid agents. But the important is that the iodides are frequently administered to patients for 2 to 3 weeks before surgical removal of the thyroid gland to decrease the necessary amount of surgery, especially to decrease the amount of bleeding.